Okay, thanks, Diane. The first 15 minutes will be the two old guys, Joe Shaker from MCW, myself from UW, and we thought it reasonable to share with you an update from the American Society for Bone and Mineral Research meeting that happened this year in Seattle from September 4th through the 8th. I'll do the first half with osteoporosis. Joe will do the last half on rare bone diseases. There are a number of ASBMR task forces that are working on issues related to osteoporosis. The first one is the atypical femur fracture. They are updating their definition. It's not going to, I don't think, change the course of mighty rivers. They're going to apparently remove minimally comminuted due to it doesn't have a lot of utility. They're still not going to come down with pathophysiology. It looks like they're going to use a lot of words, and that I think probably is true, that there's a genetic predisposition, a bone structural disposition, and then, quote, clinical pharmacological. I think I'm not sure if they're going to say oversuppression or suppression of bone remodeling. They are going to emphasize race, and I think that really is important. The data historically have shown that Asian women were at higher risk, and they emphasized that again. And you see the numbers. I'm not going to parrot them for you, but it's certainly not overwhelming benefit with native hip fractures prevented versus AFF caused among Asian women. I think they're going to come down with text that says stop potent anti-resorbers. I don't know how they're going to handle DMAB. And they commented that there's no convincing data on interventions to improve healing. And I think they are probably going to recommend a bisphosphonate holiday after 3 years of IV or 5 of oral. It's worth emphasizing, I think, the SABRE task force. And SABRE, as you see here, is an acronym for Strategy to Advance BMD as a Regulatory Endpoint. And this is a work that the FNIH has been involved with for a number of years, led by Dennis Black and Mary Boxine. And they've collected all of the pivotal pharma trial individual data. And their objective basically is to come up with a surrogate threshold effect using hip BMD. And the gist of this is that we'll be able to utilize a DEXA measured hip BMD to get new osteoporosis drugs approved, rather than having to spend literally $1 billion on a fracture trial. And I just want to emphasize that that is appropriate. I think we've lived in this world now for 30 plus years, where we've come to believe that you have to show fracture risk reduction. The data are simply overwhelming that you can use total hip BMD, and this is just an inset from one of the SABRE papers. So do not hold to the belief that fracture risk reduction is required. They are optimistic that they're going to get a favorable ruling from the FDA sometime this year. I think that that is the case because there is a company bringing an oral PTH preparation that has received FDA blessing to use hip BMD as their primary outcome variable. There are two other task forces. One is denosumab discontinuation. Sitting and listening to what they're doing with that, I'm not optimistic that anything great is going to come out of that. And I had real hopes for guideline harmonization, but it sounds like they are not going to come up with new guidelines, and they are also not going to do anything other than generalizations. It sounded to me like it's going to be Mother God and apple pie. I did want to share a couple of posters with you, and I found this to be an interesting and frankly depressing poster where they looked at a big database of individuals who had been placed on abalo, teriparatide, or romosozumab. And I've highlighted what I thought was important. The mean duration of treatment is less than a year for all of these. And worse than that, after you stop, 3/4 of folks on the PTH analogs got no treatment, and almost half after Romo. So as all of you know, if you don't follow an anabolic with an anti-resorber, the gain that we've got is promptly lost. So we're using a lot of expensive medications not to the best advantage. And I put that in here just to emphasize that obviously we need to be doing that. Uh, Wanted to highlight a study from Korea about Parkinson's. And I think all of us know that falls are bad, and folks with Parkinson's are probably more likely to fall. And these are just data documenting all of that. And there is a study out there that is taking an interesting approach. It's called Topaz. One of the investigators is Ken Lyles, who was the lead investigator on the ZOL Horizon trial. And they're doing in-home zoledronate for people with Parkinson's. So I think just to remember that when we're thinking about fracture risk factors, we need to include Parkinson's. This is a fascinating one. And as some of you may know, at Mass General, the Harvard folks are treating hip fractures in the hospital with intravenous zoledronate. And they are also doing it down to bad kidney disease. And this is the reduced dose ZA approach that they're using. So even down to 10 to 19 mils per minute, they're giving these folks a milligram of Zol. This is not yet published, but just a heads up that maybe Zol isn't the nephrotoxin that we've been led to believe. Interestingly enough, they apparently, with slower infusion time and pre-medication with acetaminophen, are not seeing much of the acute phase reaction. They're not seeing fever. So they are using Zol after hip fracture in the hospital. And here's a study. There's a number of studies out there raising concern or not raising concern about bisphosphonates after surgically treated hip fractures. And this one does raise concern. And so they found that in this huge study, 7,000 in each cohort after matching, early bisphosphonate use increased non-union and increased revision surgery risks. And they suggested delaying bisphosphonates until after fracture healing and leading with anabolics. I think the jury is still out. But it's kind of an interesting dichotomy where on one hand they're advocating let's give zoledronate in the hospital after hip fracture, and then they're saying, well, but maybe it causes more complications. So stay tuned. And these are posters. These are not peer reviewed. Joel?
So can I just make a comment on that last thing? If I recall the original uh, ZA after fracture Ken Lyle study, the analysis on that found that it worked less if it was given within the first few weeks. And the theory was that it all went to the fracture site and didn't get distributed through the skeleton. So it sounds like we can give bisphosphonates in the hospital right after. I think the question is whether we should.
I agree.
That makes Okay, so there's lots of rare bone diseases that were discussed at the Bone Club, and this is really an area of hot of a lot of activity. I'm going to talk about the ones in blue: hypopara, OI. I'm going to talk about autoimmune hypophosphatemic osteomalacia and fibrous dysplasia bone. Next slide. So I think we all know that hypopara, surgical, autoimmune, genetic, and something called autosomal dominant hypocalcemia. Next slide. If you look at the right of the slide, you see the calcium sensing receptor. And as people know, if you have loss of function mutations of the calcium sensing receptor, you get FHH. But gain of function variants activating mutations of the calcium sensing receptor cause autosomal dominant hypocalcemia type 1. It's increased calcium sensing in the parathyroids and kidneys. The PTH is suppressed at a lower calcium, hence hypocalcemia with a normal or low PTH, and hypercalciuria. And it's autosomal dominant, and they may get very hypercalciuric with normal calcium. Next slide. So standard therapy, of course, is calcium, calcitriol, magnesium, thiazide, PTH by pump, and perhaps TransCon, although I don't think it's specifically FDA approved. Encaloret is an investigational oral calcilytic, so it's the opposite of Sensipar or cinacalcet. It tells the calcium sensing receptor that the calcium is lower than it is. And as you can see, if you go over to the right of the slide, the left of the slide, in the columns, what happens is in patients with ADH1, calcium goes up, PTH goes up, urinary calcium goes down, and phosphate goes down. So this seems like this would be a great treatment for ADH1. Next slide. What's interesting is a study that was at the ASBMR about the same drugs use in post-surgical hypopara. And I think we all know what standard therapy for hypopara is, and TransCon has been a great advance. But what they found is using this drug in post-surgical hypopara. If you look at the far right of the slide, the box, that's urinary calcium. So it told the calcium sensing receptor that the calcium was lower than it is. So the calcium sensing receptor in the renal tubule held on to more calcium. Now, you might ask, is this from PTH? That there's residual parathyroid hormone and it caused PTH. So a few of the patients had a little PTH spike, but only after the first dose. So it doesn't seem like it's that simple. So this is something which may aid in the treatment of people with post-surgical and maybe other forms of hypopara besides ADH1. And I should mention, there's a lot of things that are being investigated for hypopara, including other long-acting daily PTHR1 agonists, as well as some that may be as infrequent as weekly. So that's kind of cool for what's been a really tough disease for us to manage. Next slide. So I want to talk about this autoimmune hypophosphatemic osteomalacia. There are other examples of kind of autoimmune endocrinopathies that are caused by affecting the receptor. So antibodies to the calcium sensing receptor can cause hypocalcemia if they're activating or hypercalcemia if they're inactivating. There have been antibodies that inactivate FGF23 that cause tumoral calcinosis, and antibodies to the PTH receptor that end up looking like the PTH resistance of pseudohypoparathyroidism. Well, in this study of Japan, they noted that a quarter to a half of patients with suspected TIO unable to find a tumor. And these patients have had negative genetic testing, and they checked antibodies to a bunch of relevant proteins, and they found that 4 out of 13 had autoantibodies to FEX. Now, remember, FEX, pathogenic mutations of FEX causing loss of function cause X-linked hypophosphatemic rickets. So it makes sense that you could inhibit the effect of FEX and get something that looks just like XLH. Next slide. So the NIH took a look at their patients, and they had 25 patients with suspected TIO who had, idiopathic FGF23 excess. They do a really extensive imaging to look for a TIO, and of course they do allogenetic testing, and they did antibodies to the 5 proteins up there, which can cause hypophosphatemic osteomalacia. And they found 1 in 25 had that antibody. And so this has been called autoimmune hypophosphatemic osteomalacia. They tend to have a milder phenotype than typical TIO. Burosumab is effective, not surprisingly, an antibody to FGF23. Case reports show that immunosuppressive therapy is sometimes effective. This is probably a lab we need to add in some of the patients who we think have TIO, who we can't find any explanation. Unfortunately, it's not available yet, but hopefully will be soon. Next slide. So I think if you look at the left side, the Wnt pathway stimulates bone formation and inhibits bone resorption. In the red box are sclerostin and DKK1. Ooh, there we go. Both of which inhibit this pathway. So they decrease bone formation and increase bone resorption. And so we know that that romosozumab blocks sclerostin and is effective in osteoporosis. There's another one called setrusumab, which appears effective in OI, still investigational. There was a poster at the ASBMR with romosozumab in pediatric and adolescent OI showing it's effective. But the other thing is sclerostin levels tend to be lower in OI and DKK1 levels tend to be higher. So inhibiting DKK1 may be even better. So what's been looked at is a bispecific antibody to both sclerostin and DKK1. Next slide. And on the far left is the use of this antibody. These are three abstracts from the meeting in a mouse model of OI, and it reduced fractures and improved bone structure and material properties. The middle thing is in non-human primates and showed exactly what you'd expect: increased bone formation and decreased bone resorption, as well as significant gains in bone mass. And the one on the far right is a early phase study in humans. These are not humans with OI, but this particular medicine is going to be studied in both osteoporosis and osteogenesis imperfecta. Next slide. So the last thing I want to talk about is burosumab in hypophosphatemic fibrous dysplasia of bone. As you know, FDB is sometimes accompanied by FGF23 mediated renal phosphate wasting. We treat this with calcitriol phosphate like other FGF23 mediated hypophosphatemia. But what they did was try burosumab in these patients. Next slide. And so this was 7 children and 5 adults for 48 weeks. The phosphate normalized. The alk phos decreased by 50%, suggesting the alk phos elevation isn't all fibrous dysplasia bone, but some of it's probably osteomalacia or rickets. There was an increase in TRP and TMP-GFR. And in children, there was improvement in pain. In 2 children of the 7, it was transformative. They went from non-ambulatory to ambulatory.
Mm.
Activities of daily living scores improved in 10 of 12. There was no changes in lesions and adverse effects mild. So I really think this in those patients with significant, usually they have lots of fibrous dysplasia and significant uh, hypophosphatemia, uh, may be better treated with burosumab than what we've been doing. I think that's it. Thank you. Are we going to have questions or?
Yes, we have time for a few questions.
Joel, are there any preclinical studies comparing the BMD effect of the dual inhibition with Romo?
If there are, I don't know it. Yeah, I don't know if there may be, but I haven't seen it. It's a great question. Is it any better? And
It seems like it should be.
it seems like it should be, but so can I then if no one else has questions, I want to ask a question at the fear of being a Luddite about the bone density thing. So so with the current classes of drugs, that relationship is clear. But we know there's proteins, for example, chloride channel 7 mutations cause autosomal dominant osteopetrosis type 2. And they have very high bone density and brittle bones. So it's clear that inhibition of some proteins causes brittle bones with high bone density. Maybe stimulation of others does that as well. So I'm not so sure that if a drug has a new mechanism of action, whether or not it's deposited in bone, that we should make that assumption that relationships hold. I'm also, but I don't understand why in this study they included odinecatab, which is a non-approved drug, but excluded fluoride, which is a non-approved drug, which didn't show that evidence. It strikes me that that's a little academically or scientifically dishonest.
Well, it's obvious that causing floral appetite isn't normal bone. And in the example that you mentioned, that's also not normal bone. Now, Lord knows if the FDA is going to be able to have that kind of differentiation capability. Um, uh, and I think you
So,
raise a
so
valid
you, so
point. I
you,
think you raise a valid point. But um, in my opinion, and $5 and you can get coffee. Um, in my opinion, to continue to hold to the requirement of placebo-controlled fracture trials, we will never have another osteoporosis drug
yeah. So I think the answer is that they have to have reliable fracture data in preclinical studies,
or
not
bone strength or bone strength
or
data.
bone strength, something that proves that the bone. So I think that's the answer. That you have to prove that inhibiting that protein or stimulating that protein doesn't cause dense, brittle bones. I think that's the right answer, but I don't know.